Hello friends, welcome again. Today we will be talking about microcephaly. In particular, we'll be focusing on its causes, diagnosis, workup, and management. So without further ado, let's dive in and get started. Microcephaly is defined as occipitofrontal circumference. This is commonly known as head circumference, but in medical terminology, we call it occipitofrontal circumference because we have to measure the diameter of the skull from the occipit to the frontal bone. So that's why it's known as OFC, or occipitofrontal circumference. So a baby whose occipitofrontal circumference is less than 2 standard deviations than normal for that age group or for that sex or for that ethnic origin. If it is less than that, then we would call it as microcephaly. Now, please keep it in mind that certain textbooks also take it as 3 standard deviations. But for this lecture purpose, I would take it as 2 standard deviations because most of the textbooks agree that occipitofrontal circumference or heart circumference, which is less than 2 standard deviations, which is normal for that age group, for that sex, and for that ethnic origin, that would be classified as microcephaly. Now, if you are plotting the OFC or the head circumference on the centile charts, then this corresponds to the OFC or occipitofrontal circumference of less than third centile. Obviously, it's a bit difficult to understand the standard deviation because 2 standard deviations, they actually incorporate 95% of the population. So within 95% of the population would be having a head circumference between a certain range. Less than that would be considered as microcephaly. How do you plot it on a chart? Well, basically for that we have got the OFC centile charts. In the bottom of this slide, you can see that this is basically an OFC chart on which it plots the occipitofrontal circumference in centimeters against the age of the child. So we have to plot. So again, you can see different lines going in like in curves, so the lowest one is the third centile. So the lowest curve corresponds to the third centile. So any child whose occipitofrontal circumference falls anywhere below this third centile, that would be classified as being a microceph child, or in other words, that would be classified as microcephaly. Now, prevalence varies by region. The European prevalence is 1.53 per 10,000 births, and this is based on the population data which was calculated on different age cohorts starting from 2002 and ending up in 2013. So over 10 and 11 years period, they calculated European prevalence of occipitofrontal circumference less than the 2 standard deviations, and they found out that out of every 10,000 kids who are born, around 1.5, or in other words, you can say over 20,000 births, at least 3 children are born whose head circumference is less than the 2 standard deviation, or simply it falls less than the third centile. In the rest of the world, it varies again more so in developing countries because of the poor primary healthcare services, especially the poor level of maternal and child health services. So the Asian and the African prevalence is high as compared to the European prevalence. Now it came into the limelight basically in late 2015. In late 2015, World Health Organization suddenly reported that there was a sudden surge in cases of microcephaly in Brazil. And that was of interest because it never had happened in the past, like all of a sudden increase, which was just like, touching the epidemic proportions. And then they later on found out that it was actually related to an epidemic of Zika virus infection that had led to an increase in the birth of children with microcephaly. So they researched on that, and now it is an established fact that Zika virus infection in early pregnancy is related with increased chances of children being born with microcephaly and with brain malformations. So that is one thing that was in late 2015 that the microcephaly came into limelight because of the sudden increase and its association with the Zika virus infection. Now, coming to the types and causes. Basically, we divide them into 2 types, primary and secondary. Or in other words, we can have like primary cause of microcephaly and secondary cause of microcephaly. Or to further simplify it, primary simply means that the problem was there antenatally. So before the baby was born, there were certain changes, there were certain insults, or there were certain like sort of an infections which basically interfered with the development of the skull or with the development of the brain, and eventually led to the baby having a small head. Secondary causes simply means that it happened after birth or during the time of the birth. So basically it means that there was nothing wrong with the developmental aspect of the brain or the skull, but what happened, there were certain events close to the birth that led to certain changes, which eventually led to an arrested development of the brain or the skull, eventually resulting in microcephaly. So let's dissect them one by one. So taking the primary causes of microcephaly, again I told you primary means that these causes, they occur in the antenatal period, and on top of it are the genetic and chromosomal conditions. Now, by and large, most of the genetic abnormalities or chromosomal abnormalities, because they are interfering with the genes, and obviously these are the genes which code for different types of proteins. All of the cellular metabolism, growth and development is basically coded in the genes. So if the genes are faulty, and these genes are on the chromosomes, so the chromosomes are faulty, in turn genes are faulty, then what would happen? That can interfere with the development of the brain. Certain types of trisomies are quite notorious that they are associated with microcephaly, especially trisomy 13, 18 and 21. You know very well, trisomy 13 are Beta syndrome, trisomy 18 or Edwards syndrome, and trisomy 21 are Down syndrome. Now, not all of these cases would be having microcephaly, but by and large, again, because these are spectrums, again, you can be falling anywhere. They have got different anomalies, and they are syndromes, so you can be having a few features present and a few features absent. So by and large, majority of these trisomies would be having microcephaly, because the genetic abnormalities in these trisomies, where you've got an extra chromosome either on chromosome number 13, 18 or 21, it interferes with the development of the brain and the skull, and these kids are born with small heads or microcephaly. Another one is Angelman syndrome, basically where the problem lies on chromosome number 15, and it can be because of the deletion or uniparental disomies. Angelman syndrome and the Angelman syndrome basically is a condition in which the child can have microcephaly, and they've got other features as well. They might have seizures, they might have low IQ and characteristic faces. So genetic and chromosomal conditions are by and large the major cause, primary cause of microcephaly. Then in developing world especially, congenital infections have got a big role, obviously because of the poor maternal and child healthcare services, because of the poor environmental hygiene. Pregnancy related infections are still common, and especially infections by the TORCH groups. So toxoplasmosis, rubella, cytomegalovirus, herpes, HIV, or Zika virus. Zika virus is more common in tropical regions, especially in South America, in Brazil and other in Amazon basin, and it's also common in certain parts of Southeast Asia. There are heavy rains, because this is caused by the bite of the Aedes aegypti mosquito. So where this mosquito is prevalent, Zika virus is also prevalent. So Zika virus, basically, as I told you earlier, that it came into the limelight in 2015, where in the Brazil there was an epidemic of Zika virus infection, and later as the epidemic passed away, they found out that a cohort of children was born like with a very high prevalence of microcephaly, and then they did the investigation. They found out that they were related. There was an association between Zika virus infection in pregnancy and microcephaly in their offsprings. So congenital infections, toxoplasmosis, rubella, congenital cytomegalovirus, and herpes and HIV are related with microcephaly. Then certain types of inborn errors of metabolism. Inborn errors of metabolism is a very wide group of disorders which are basically enzymatic problems. So the enzymes in cellular pathways, they are affected at some point along their path, and it leads to accumulation of the substrate. Now, every substrate, when in huge amount, that becomes a bit toxic, and that interferes with cellular metabolism and with cellular division. So certain inborn errors of metabolism can lead to microcephaly. Similarly, certain types of brain malformations, usually they can be part of some syndrome, or they can also occur without any other syndromic manifestations, and they also result in microcephaly. One is holoprosencephaly. Holoprosencephaly simply means that the forebrain, that is the part of the brain which we call as forebrain in embryology, that fails to divide into two cerebral hemispheres. So when it fails to divide into two cerebral hemispheres, then we call that condition as holoprosencephaly. And obviously, because that also interferes with the development of the brain, that leads to microcephaly. The other brain malformation is lysencephaly. Lysencephaly means that there is absence of sulci and gyri. So the brain surface area does not increase by the production of the sulci and gyri. So what happens? You've got a brain which is very smooth. It hasn't got those gyri and sulci. That condition is known as lysencephaly, and lysencephaly also leads to a small head circumference or microcephaly. Then certain types of drugs are very toxic if taken during pregnancy, and they interfere with brain development, lead to microcephaly, like thalidomide and valproic acid, which is basically an anti-epileptic medication. So these are some of the common primary causes of microcephaly. Moving on to the secondary causes. Again, I told you secondary cause of microcephaly means that the problem occurs around the time of birth or immediately after that. Now, again, by and large, the biggest secondary cause of microcephaly are perinatal insults. So perinatal insult means anything around the time of childbirth which interferes with oxygenation of the brain tissue. We call it hypoxic ischemic encephalopathy. So an obstructed labor, placental problems, maternal issues like preeclampsia, like eclampsia, like placental insufficiency, like hypertension, or certain reasons in the placental vessels, vasa previa, and things like that, they can lead to less oxygen being supplied to the brain, and that's a very critical area. So the brain cells, they don't get enough oxygen and they die. And remember, when brain cells they die, they cannot regenerate. So that leads to arrested brain development. And after some time, they would be having small heads or microcephaly. So by and large, the most common and the most important secondary cause of microcephaly is hypoxic ischemic encephalopathy. Then the second biggest secondary cause are acquired central nervous system infections. Again, more common in developing countries. So infections like meningitis, encephalitis, or certain types of phenomena. These are not infections, stroke itself, because strokes leads to occlusion or hemorrhage in a certain part of the brain, and that leads to arrested development because those brain cells would die. Similarly, encephalitis, which means inflammation, infection of the brain cells or of the meninges, which is known as meningitis, that can result in arrested brain development because the neurons would be damaged, they die, they cannot be regenerated, and over a period of time that would lead to microcephaly. Then another third important reason, again very uncommon, that is Rett syndrome. So Rett syndrome is an X-linked dominant condition which occurs exclusively in females, and it is known as secondary microcephaly because these kids are fine till like between 6 and 9 months of age. They're absolutely fine, but after that time they start developing towards the, like, in other words, they start regressing. Development goes on the negative side, so they lose their acquired skills. So let's say if they were sitting, they're not able to sit. If they were able to smile, they are not able to smile. And what happens? There is neurodevelopmental regression. There is loss of neurons. Problem is on the MECP2 gene. So MECP2 gene deletion usually causes this problem after 6 and 9 months of age. So they are fine up to 6 to 9 months, but after that, what happens? There is neurodevelopmental regression, loss of neurons, and we call it acquired microcephaly, because then after that the head circumference doesn't grow anymore. The child can grow in terms of his body weight and things, but relatively the skull would be small. And if you plot them for their age, as the age advances, it will remain static. So eventually it would go down below the third centile and become microcephaly. So Rett syndrome is an uncommon but important cause of acquired microcephaly in girls, especially if they were normal up to 6 to 9 months of age, and after that they start losing their acquired skills, developmental skills. So again, this list is not exhaustive, but this actually focuses on some of the common causes of microcephaly. Moving on to the pathogenesis. Now, a little bit about pathogenesis. What happens, like when we say microcephaly, whether it's caused by congenital infections, whether it's caused by some syndrome, what has happened? For that, we need to understand how the neurons develop. Now, the neuronal stem cells, the undifferentiated cells, which then develop into glial cells, and some of them they develop into neurons. If you look at the left side of this diagram, so these are cells in the green shade. These are basically the neuronal stem cells. So neuronal stem cells, they divide. Like for example, this cell has divided into two further cells. So they can develop into the neuronal support tissue, which we call as glial cells. Now, as they divide and redivide and redivide, a time comes when some of them, rather than dividing into two equal size of glial cells, one of them differentiates and becomes a neuron. Like for example, if you look, this is a neuronal stem cell, and then it divides into, rather than into two glial cells, it divides into one glial cell, and the other one develops into a neuron, a functional neuron, which performs all the important functions of the brain. But normally the neuronal stem cells, they do not randomly divide to make neurons and glial tissue. There is a theory which we call as transit amplification. So transit amplification simply means that the glial cell first of all divides and redivides into a big pool of glial cells, and once there is a big pool of glial cells, only then they would start differentiating into neurons. So the more pool of glial cell, the more neurons can then later be developed from them, and the baby would be having a proper brain with adequate number of neurons. But what happens in microcephaly, whether that is because of genetic problems, whether that is because of some form of viral insult, that the viruses have destroyed the glial cell or changed the architecture of the cells in such a way that the functions are impaired. So what would happen because of that? Instead of the cells, the glial cells, being dividing into a pool of so many glial cells and then developing into neuron, what they do is they start developing into neurons. Now, this leads to a caveat. If you, let's say, if you have got more, let's say, pool of glial cells because of rapid division and redivision, then that big pool would lead to big number of neurons. But once, if you have got less cells, less glial cell, and they're not dividing and redividing into the glial cell pool, but rather they develop into neurons. So obviously you've got few glial cells, and those few glial cells would give you few neurons, and few neurons means small brain, and small brain would mean microcephaly. So the end result of this arrest of a process which is known as transit amplification. Transit amplification means that they amplify transiently glial cells, they amplify transiently before turning into neurons. So if that is arrested, what would happen? The number of neurons would be less because there would be a small pool of glial cell. So the end result is a decrease in the number of neurons because the neuronal stem cell pool is not amplified through the process of transit amplification, leading to a small brain, and that leads to microcephaly. Now, this process is solely important in primary microcephaly because this process is occurring during the developing brain. In acquired microcephaly, it's simply the damage. You know that the neurons cannot regenerate. So let's say if you have got like 2 billion neurons, and let's say 500 million of them are destroyed by an infective process, obviously you have got a small pool of neurons then. and the brain is not going, all the brain development that occurs in the first 2 years. So when that is not happening, especially these types of infection, neuronal insult in the first 2 years can result in microcephaly. So what would happen? These infections, these inflammations, they would result in loss of neurons. They do not regenerate. So a small brain means a small skull, small head circumference, and that would mean microcephaly. So I hope you have understood the pathogenesis of microcephaly. Let's move on and talk about the workup. So obviously somebody can bring a child to you and say, doctor, his head is very small. Now usually small heads, obviously just by looking at them you can detect that they've got small heads, but still needs to be plotted on charts, and you have to confirm. So you have to plot them on a centile chart and make sure it is less than the third centile in order to label it as microcephaly. But usually they've got small skulls and usually sloppy forehead, so the forehead is sloping backwards. So their heads are small as compared to their body. So the first step is to plot OFC on the chart and confirm microcephaly. So you have to confirm what it is a confirm. Then the next step is to take a detailed history. We need to know. Because we know that there are primary causes and secondary causes, we have to focus on antenatal history. We need to ask about the type of care that she had, whether she had any infections, whether she used any drugs, whether she had like some scans and whether those scans picked up anything. You would also ask about the natal and postnatal history. So how was the labor? Was it prolonged? Was there early rupture of membrane or prolonged rupture of membrane? Were there any perinatal infections? Whether there was any problems with the fetus, like fetal bradycardia, prolonged fetal tachycardia, or other issues. Similarly, you would be asking about postnatal history. So what happened after birth? Did the child cry immediately? Did he have prolonged jaundice? Because connectors can sometimes also cause microcephaly. So you'll ask about any infections, any jaundice in the postnatal period which might have contributed to microcephaly. So it's very, very important that you take a detailed history. You would also ask about family history. Some people might have a familial small skulls. So you would ask if there is a history of small heads in babies in their family. You would also ask about consanguinity, because that gives you an idea if there could be any inborn errors of metabolism or babies dying at an early age. So once you have taken a detailed history, you would do a detailed head to toe examination. You would look for any dysmorphism, because dysmorphism would guide you towards some syndromic picture or genetic causes. You would also do anthropometric measurements. So you would see whether the height and the weight are also affected or not. Because let's say if the height is also affected, the weight is also affected, probably you are looking at some form of syndrome where all the parameters have been affected. But if only brain is affected and the rest of the parameters are fine, then there is something which has just hit the development of the brain, or something which has caused damage to the brain only. And you would also focus on hearing and vision to see if the hearing and vision of the child is fine or not, because that would also help in managing this condition later on. Because obviously if the head is small, you cannot do anything to increase the size of the head, but you can focus on the associated issues like hearing and vision and give them some aids which can help them to lead close to normal life. Now, where needed, where there's a history of consanguinity or early neonatal deaths, or you think that the child smells a bit abnormal, something, you need to do metabolic panels. So metabolic panels are the test which can guide you towards the presence of an metabolic pathology. So at the very basic level, you would do an acid base status. You would do a blood gas which would tell you whether the child is acidotic or alkalotic. You will focus on the lactate levels. You also need to take bloods for serum ammonia levels, plasma acyl carnitine levels, urinary organic acids, urinary reducing substances, and plasma amino acids as well. So there is different trusts have got different guidelines regarding these metabolic panels. So if you suspect that, then you need to do those metabolic panels as well. Once you have done all these things, then in neonates, cranial ultrasound is the best modality to begin with. Like cranial ultrasound, because less than 6 months of age, you've got these open anterior fontanelle, which can be used as a window of opportunity to look into the skull and find certain things. Like, for example, in congenital cytomegalovirus infection, there are periventricular calcifications, and if you put an ultrasound probe, you can find that there the periventricular areas are calcified. That can give you an idea that this is probably congenital cytomegalovirus infection. So cranial ultrasound gives you an important answer to the structure of the brain in the neonatal period. For older children, we can use the MRI. Remember, MRI is always preferable to CT scan. CT scan yield is not very good when it comes to, assessing or working up microcephaly. So MRI is the preferred modality. MRS, which stands for magnetic resonance spectroscopy. Now, this is slightly different from MRI because this usually looks at the metabolic activity in different parts of the brain, especially if you are suspecting metabolic problem. So metabolic, this magnetic resonance spectrometry, that would look at the different regions of the brain and see what metabolic activity is going on. So certain types of metabolic problems would highlight those areas, so you can get an idea what type of metabolic problems the child might be suffering from. So magnetic resonance spectroscopy is a very good modality of investigation where you are thinking that there is a metabolic problem affecting the brain. And EEG can also be done where indicated, where the child has got seizures. So you can do EEG to find what type of seizures are there, and that can also give you a clue of the underlying associated conditions. If you think that the child has got some familiar dysmorphism, then you can do karyotyping, or if you think it is syndromic but dysmorphism, but it's not like matching any known familiar dysmorphic pictures, then you can go for genomic sequences. So genomic sequencing can identify those things which are normally not part of the usual genetic or chromosomal problems that we see in routine practice. And where you think that the mother might be having poor antenatal care and she might have some form of congenital infection, you can screen them for torch infections. So this is a detailed workup. So when you come across a microcaph child, you need to plot down the graph, start from the history, do the examination, and then certain workup. So the workup would include, again, depending on what your history is pointing towards. So you've got a broad differential, then you can do for example, if you come across a child who was fine for 6 to 9 months of age, she's a girl, and then started regressing back on the developmental skill, then you'll be thinking about other issues. You'll be thinking about TRET. So if you're thinking about TRET, then you don't need to do the let's say you don't need to do the metabolic panel. You need to do the genetic testing. So probably you'll be looking for MECP2 gene deletion. And so that's how you would work up these kids who have got microcephaly, again, depending on what you find. So again, you can start from cranial ultrasound, you can do an MRI or MRS, EEG where needed, and metabolic panel, karyotyping, etc., etc. Here are some images that I want to show to you. And here, the first one here, this is the an image from the cranial ultrasound. So you see the probe has been placed. This is the probe which has been placed at the anterior fontanelle. So you can see this is the cross section of the brain. So you can see these are the ventricles, two lateral ventricles, and you can see that just adjacent to the ventricles, you can see these whitish shadows. So these whitish shadows are calcifications. These are calcifications. There are some more calcifications in the basal ganglia as well. So these periventricular calcification is also known as periventricular leukomalacia, and it is quite characteristic of congenital cytomegaloviral infection. So this is an ultrasound, a child who's got microcephaly, and ultrasound has been done in the neonatal period, and it's showing periventricular calcification. So you are thinking of congenital cytomegalovirus infection that can be further confirmed by urine for CMV presence. In the other picture, you can see that there is comparison between a normal brain and a lysencephaly. I told you lysencephaly is a smooth brain which hasn't got any sulci and gyri. So here you can see there are a lot of sulci and gyri, which increases the surface area of the brain. But here you can see it's a very smooth, no sulci, no gyri. So this is basically a small brain leading to a small skull and microcephaly. So this is lysencephaly. Here you can see that there is you can't see an appropriate division of the forebrain into two parts. So there is no division. It's just like one single large part of the forebrain. It has failed to divide into two cerebral hemispheres, and this with big ventricles, and we call it as holoprosencephaly. This is quite common in trisomy 13 and 18, more so in trisomy 13. So it is usually associated with trisomy 13 and to some extent with trisomy 18 as well. Holoprosencephaly, which means that failure of the forebrain to divide into two separate hemispheres. And finally, coming down to management. If a child has got a small skull, remember, and the brain tissue itself is less, nothing, you can't increase the size of the skull. Yes, sometimes if there is acquired skull problems like craniosynostosis, premature closure, then obviously you can do skull repair and other things so that the brain development is not arrested. But that's only like one exception, where most of the insults have occurred in utero and the baby is being born with a small skull. There's nothing much you can do. So the management then depends on management of underlying problems where they can be corrected. Remember, not all problems can be corrected, but there you can correct it. Like, for example, if the vision can be corrected, you will correct it with via refraction. Where the hearing can be corrected by, giving them hearing aids, well, you can do that. Where it can't, you can't. So management of microcephaly simply means management of the underlying conditions where it can be managed. Remember, science has advanced a lot, but still it hasn't advanced to the level where you can address each and everything. But depending on the centers, depending on the level of support or the level of investment in healthcare services, you can still go for some of the things that can go a long way in improving their quality of life. So the associated problems which usually happen with microcephaly are visual problems. So vision can be corrected by refraction or giving them state-of-the-art advanced visual aids. Hearing can be corrected by the help of hearing aid. Seizures can be corrected with anti-seizure medications, anti-epileptics. Then if they've got problems, because usually small brain might lead to problems with the motor system, so they might not have a proper gait, they might be bedridden, so you need to give them some form of occupational therapy so that they are able to move their limbs and they are able to do some basic stuff for themselves. Speech therapy also comes in here, and where they can't talk properly, speech therapists can give them some form of speech therapy, so at least they've got a little bit of language where they can make themselves understand. Physiotherapy is also important if they are bedridden or something and they can develop joint contractions. So physiotherapy is very important that they don't develop those things. And nutritional support, because obviously if they've got problems with swallowing and other things, then they need to be given some form of nutritional support in the form of tube feeding or enterostomies, putting some tubes directly into their stomachs or intestines to give them some form of nutritional support, especially if they can't swallow or if they've got issues with their swallowing process. So by and large, management depends on management of underlying conditions. Like, for example, if there is a metabolic condition, you can correct if the science advanced to the level that you can give them some substrates and things like that, or enzymes. But in most of the cases, it's still supportive therapy, which just aims to increase the quality of life. If you can't correct the underlying defect, then obviously you can do something to improve the quality of life. So it is a multidisciplinary approach. So multidisciplinary approach means that the pediatrician, the primary pediatrician, the neurologist, the physiotherapist, the nutritional or dietitian, nutritional therapist or dietitian, the GP, the community pediatricians, the social worker, they all have to work together in order to provide all these things which are known as supportive treatment to a child who has got microcephaly. So this was all about microcephaly. We discussed the definition, and just to summarize it, any child who's got a head circumference of less than 2 standard deviation for his age, sex and ethnic origin, or in other words, somebody whose head circumference is falling below the 3rd centile on the head circumference chart is microcephalic, you need to find out the causes. That could be primary or secondary. Again, you always plot it on the chart, and from there you start by taking a good history, focusing on antenatal, natal and postnatal history, on the family history, drug history, and then you go down doing a complete examination, especially focusing on the neurological aspects of the examination. And then you can do a workup which can include a battery of different things, like you can do cranial ultrasound, MRI, MRS, EEG, basic metabolic panel, karyotyping, genomic sequencing, looking for any metabolic problems by screening their urine, and looking for other things that might be causing the microcephaly, or which can give you an idea what was wrong with this child when this thing happened. And that can go a long way in planning your management plan for this particular type of child who's got microcephaly. So I hope you have enjoyed this lecture. If yes, give me a thumbs up, and if you subscribe to my channel, it would be very highly appreciated. It gives me the motivation to bring you more lectures for you people. And the most important thing, if you haven't understood any bit of it, or if you've got some questions, you can put it down in the comment section below, and I will try my level best to answer it as soon as possible. So I wish you a very good day. Take care. Bye bye.